Da vil jeg bare si velkommen til dette webinaret med Bill Taylor. Vi har gledet oss veldig mye til dette. Jeg ville bare si også at det blir sendt et opptak av webinaret i etterkant, så dere vil motta en e-post med en lenke til opptak. Så ja, da vet dere at den kommer. Det er veldig mange deltakere, så det tar litt tid å sende ut, men vit at den kommer. Okay? Yes.
So, Bill, take it away. Thank you very much that you said yes to this one. So we are looking forward to hear you, and yes, good luck.
Thank you very much. Thanks for asking me along, Iveta and Quintet. It's nice to be here. Thanks everyone else for giving up your morning and being here. This talk came about really because I've been treating a lot of my patients have hypermobility, and I felt that sometimes we didn't maybe know enough or concentrate so much on the pelvic floor. And then when I produced this talk, it's really about connecting the dots across the system, and it's not just about pelvic health and isolation, but it's how the pelvis connects to the rest of the hypermobile patient. In hypermobility spectrum disorder, HSD and hypermobility Ehlers-Danlos are heads. Now, I have a little bit of dyslexia, and my HSD sometimes becomes HDS. So if I do HDS instead of HSD, just ignore me. That's what I mean. My title really, the whole point was we're never really dealing with a single system problem. And the title Bend It Like Beckham is deliberate, really. It's a nod to the kind of 80s movie, soccer movie, but also a reminder that flexibility doesn't necessarily equal function. So my aim today really is to move beyond local pelvic floor thinking, integrate urogynecology, MSK, vascular, autonomic, pain science and rehab into clinically what we often see is patients who bounce between specialities. They've got fragmented care, symptoms that don't fit into neat boxes. So today really is hopefully is about pattern recognition, clinical reasoning, and practical rehab strategies. It's not just about pelvic floors, it's about whole person load management. So I'm going to share the screen. Let me just see. No, not that one. I'm going to share my screen here. And hopefully you guys can see that. Yeah, so hopefully you guys can see that. Yeah, so there's if you've got questions, put them in the chat. I think Iveta and her colleagues from Quintet are going to collect that stuff, and if we've got time at the end, I'll answer them. And if not, then they'll send them to me and I'll answer them as we go. I'll answer them later on. So I think if I go to my first slide, every second. There we go. So what do we need to know about this? We need to know about it because there's a high instance about this, predominantly in women that are assigned female at birth. So in female patients, HSD is 20 to 30% present in the population, and only a proportion of these individuals will become symptomatic. The true prevalence itself is really uncertain due to variability in diagnostic criteria and under recognition in clinical practice, and we'll talk a little bit about that in a little bit later. Often these patients are often labelled as just flexible or very bendy, and it's often seen in young dancers or athletes or sports people. I think before we go further, it's worth appreciating just how common this actually is. There's obviously multi-system involvement, musculoskeletal system, autonomic system, gastrointestinal system, and then pelvic system, pelvic health. There's an increased risk of incontinence, constipation, prolapse, and sexual pain. And why it matters really is because there's this hidden stigma. Oftentimes the patients are told there's nothing wrong and there's nothing structurally wrong, despite many tests and investigations. You've just got some irritable bowel syndrome. It's just pelvic floor weakness. But the reality really is that the symptoms are real, they're interconnected, and they have a high health burden, really. I think misunderstanding drives mismanagement, and they tend to be dismissed too readily. Um, so what is hypermobility system disorder? Hold on a second. It's a physical trait. It's more common than heads. The majority of symptomatic hypermobile presentations fit underneath this heading. It's a clinically based diagnosis, and it looks at generalized joint hypermobility, and it's often benign. And it's diagnosed with the Beighton score only, and we'll talk a little bit about the Beighton score in a minute. It may be localized to one joint, it can be localized to the peripheral joints, or it can be generalized. But the generalized HSD still sticks in that HSD arena because it doesn't meet heads criteria. I'll explain what I mean about that in a minute. But they can still present with chronic musculoskeletal pain, joint instability, recurrent subluxations. The proprioceptive impairment, so a sense of not knowing where your joints are in space, pelvic floor dysfunction. And as children growing up, these kids often maybe have coordination issues. They can do tricks with their joints. They can move themselves and put themselves into funny positions. They have party tricks that everyone thinks is quite funny, that being able to put their leg behind their head. So I think the point is, though, all heads patients have generalized hypermobility, but most folk with hypermobility syndrome disorder don't have heads. So generalized joint hypermobility becomes clinically relevant when they get symptoms. So some of these guys might not actually get symptoms. So like I said before, the prevalence of HSD is about 20 to 30% of the population. Only a proportion of these individuals become symptomatic, and the true prevalence is uncertain. And again, they're often just labeled as flexible or bendy. So what is HEDS? What is hypermobile Ehlers-Danlos? So hypermobile Ehlers-Danlos syndrome is an inherited connective tissue disorder. It affects 1 in 3 to 5,000 individuals, and there are strict criteria that were set up in 2017. Now, as I'm speaking today, and in the next couple of months, there's going to be some new clinical criteria published, maybe around September time, as part of a global consortium to try to update the definitions of what HEDS and HMSD is. The clinical features of HEDS are generalized joint hypermobility, connective tissue fragility, chronic pain, and instability. There's, again, a multi-system involvement, MSK, so musculoskeletal, autonomic, gastrointestinal, urogynecological. Now, for HEDS, we have about 13 different types of Ehlers-Danlos syndrome, but which all have genetic markers for them. But the only one we don't have a genetic marker for is for hypermobile Ehlers-Danlos. Now, we're getting close, but we're not quite there yet. Patients often get fatigue and reduced load tolerance. They have changes in their autonomic and pelvic health symptoms. And they have a diagnosis of increased mobility that has systemic implications. So the key diagnostic features of HEDS are based on 2017 international classification criteria, and they look at generalized joint hypermobility, which is assessed using the Beighton score, which has all sorts of issues with its validity and reliability, but it is what we're using at the moment until we have something maybe better. Family history of hypermobility. Musculoskeletal complications, and then an exclusion of other connective tissue disorders. So if you look at the big picture, hypermobility symptom disorder, the prevalence, it's common, it's likely percentage of the population have it. So there's a lot of people in the population have it that don't have any symptoms. Heads is quite rare. It's less than 0.02 to 0.03% of the population. And the position on the spectrum is HSD tends to be very broad and heterogeneous in that people present in many, many different ways. When you actually have a definition of heads, you tend to have a much narrow presentation, and you've probably fit under pardon me, a defined subtype. So systemic features are variable and limited in HSD, and in heads they tend to be more consistent in multi-system. The diagnosis is clinical, but less strict criteria. And the heads really is still clinical, but sticks to the 2017 strict criteria. The clinical road can be mild to 0 to moderate to sometimes complex. The clinical load with heads tends to be often moderate to severe. So we really need to review the 2017 criteria because there's a whole bunch of different questions around this, and the benign hypermobility criteria are often misinterpreted by medical people, by friends, family, by coaches, and they contribute really to clinical minimization of people's symptoms, which can often lead to delayed care. And it can often contribute in the past to under-recognition and invalidation of patients' concerns, really. So the new classification is suggesting that we remove benign joint hypermobility syndrome and joint hypermobility system. We've got a heads with stricter criteria, and we have HSD with symptomatic hypermobility but not meeting the full criteria. Now, the heads versus HSD separation can actually be seen as quite controversial because there's some researchers are hypothesizing that there are points in a spectrum rather than distinct disorders. Some still support this clinical distinction, but we'll see what they say in September with the new guidelines. So the road to 2026 really is we need a new diagnostic framework. 2017 criteria were designed to increase diagnostic specificity, and there's a need to move beyond the Beighton score limitations, demographic limitations, but it has age, sex, ethnicity limitations. I think there's a poor reflection of functional impairment. It remains it's a useful, quick screening tool. It's necessary, I think, at the moment, but it's insufficient as a standalone diagnostic tool. We need to incorporate genetics and patient-reported data to get a much better idea of what this patient actually has. I think the current system is still imperfect, it's clinically challenging, and it's not fully representative of the patient experience, really. We need a more integrated, multidimensional framework, and I think what we have works, but it's not enough, really. The real reason they had the 2017 criteria really was actually to reduce the overdiagnosis of heads, and they did achieve that to an extent, but maybe at the cost of sensitivity, missing some patients. We get more precise, but potentially less inclusive. Let me go to my next slide. So the Beighton scale, which we were taught, the Beighton score, has big demographic limitations, and we need to remember that it varies with age, with sex, with ethnicity, and the thresholds. If you're a child and an adolescent, the score is scored out of 9. And in child and adolescents, you have to have a greater than 6 out of 9 to have a positive score. In adults, you have to have greater than 5 out of 9 to have a positive score. In older adults, because we get stiffer as we get older, because our collagen type changes over 50 years, we have to only have a score of 4 out of 9. Now, these thresholds come from the International Criteria 2017, and they reflect age-related mobility loss. We have to remember that it's not it's a screening tool, it's not diagnostic. It doesn't capture symptomatic hypermobility. It does not assess load tolerance, control, or pain. Limited joint coverage, well, there's no looking at shoulders, hips, ankles, or pelvic floor insight. And we often get false negatives because previously hypermobile individuals can tighten over time, and even within their age groups can score lower than the criteria would say they should, but they still can be hypermobile. So we look at things that, and I think everyone's kind of really aware of this. We've got like the fifth pinky or the fifth finger. You test both sides. You rest the palm of the hand and forearm on a flat surface with the palm side down, finger straight out, and then bend it up. And can the fifth finger be bent upwards at the knuckle to go back beyond 90 degrees? If yes, you add 1 point for each side that happens on, remembering that it might not happen on each side. You test their thumbs. You, with the palm out straight, the palm facing down and the wrist fully bent downward. As you can see, I don't really have it. Can the thumb be pushed back to touch the forearm? So if I am like an old stiff guy, so my thumb goes to here, and it's a significant difference from here to the forearm. If yes, you add 1 point for each thumb. Elbows, you're looking at hypermobile elbows, so they extend more than an extra 10 degrees beyond a normal extended position. And if yes, you add 1 point for each side. Knees, while standing with the knees locked, bent backwards, does the lower part of either leg extend more than 10 degrees forward? If yes, you add 1 point for each side. And then the spine, bending forward, can you place down hands flat on the floor in front of your feet without bending your knees? And you can add 1 point to that. So because we need to almost kind of make this a bit... what am I trying to say? It's like we want to have another kind of test, which is the 5-part questionnaire, 5PQ. And this is an assessment of historical laxity, really, to know has there been a change in how you've been feeling in the past. So symptom profile, looking at did you have any pain, instability, or fatigue? Functional tests, looking at control under load, and then context is pelvic health, problems, and sex. And the questions we ask are things like, can you now or could you ever place your hands on the floor without bending your knees? Can you now or could you ever bend your thumb to touch your forearms? So it's asking some of those questions to the Beighton, but it's asking it in a historical way. And then as a child, did you amuse your friends by contorting your body into strange shapes or splits? And as a child, teenager, did your shoulder or kneecap dislocate more than on one occasion? Then the other question is, do you consider yourself double jointed? What's your life experience with this? And a positive 5PQ test is greater than 2. Likely indicates a historical generalized joint hypermobility and should prompt further assessment. We should be looking at these patients a bit more. So why is diagnosis so important, and why can't we just go on and treat these guys? I think it's because it does give us a criteria to put them into a diagnostic category, which would then guide appropriate management. Because generalized joint hypermobility is often benign, but HSD and HEADS requires loads management, motor control and proprioception training, multi-system awareness, looking at fatigue, autonomic nervous system, and pain. No diagnosis equals a risk of overloading and under-treating. Because these patients, we have to gauge and judge the way we're going to expose them to load, the way we're going to expose them to exercise, in a really careful way. It also explains the patient's experience. It's a sense-making thing. It kind of makes sense of their symptoms. They're often quite fearful. They often don't understand why they've had multiple systems. They often feel a bit confused because no one's given them a diagnosis. They've often been passed from pillar to post. They're often very frustrated. They're often been the narrative that they've been told there's nothing's wrong, and that really they might be a bit bendy, but other than that, they're quite well, and nothing really to be done for them. And I think this is really especially important in pelvic health presentations and also persistent failed rehab patients who have gone from one physiotherapist to the other without improvement. So we do have this emerging shift, really, that HEADS is more than just collagen. It's not just about stretchy ligaments. Traditionally, we've talked about heads as being a structural connective tissue disorder, but there's emerging evidence that it's a multi-system dysregulation disorder involving the immune system, the nervous system, the extracellular matrix signaling system. The immune system it gets involved because of mast cell activation syndrome, the nervous system because of POTS, small fiber damage, and neuropathy, central sensitization, and sorry, as postural orthostatic tachycardia syndrome, which is a kind of a, we'll talk a little bit about that later. And then we've got this kind of, in the extracellular matrix system, we've got it's a signaling environment where tissue turnover and repair processes and load adaptation issues happen. So heads can be a disorder of connective tissue regulation involving immune, neural, and ECM signaling. It's not just a single structural defect. I think, so what does this mean in the clinic? I think it helps us perhaps focus more on what actually matters to the patient. And until the diagnostic question is cleared up, we need to understand that heads versus HSD as a working model rather than rigid categories. Think of them as points on the spectrum. It's a clinical model, not a binary decision. So sometimes we get a bit hung up on saying, do you have heads or do you have HSD? Well, maybe we don't need to do that at the moment, and maybe things will be clearer later in this year when we've got the new paper that's published. So we want to focus really on the what actually matters to the patient. You know, what's the symptom burden? What is the patient experiencing? Do they have pain, bladder symptoms, fatigue, functional limitation? Really treat the impact that this disorder has, not the label. We want tissue behavior. We want to know, how do tissues load to reload, repetition, fatigue. It's key in hypermobility that patients often have reduced tolerance, delayed recovery, and this really has to guide our rehab progression. Comorbidities, we always need to screen for pain sensitization, autonomic nervous system, POTS, pelvic floor dysfunction. These often drive the symptoms more than the joint laxity itself. So they might, if you miss these, then you almost miss the real drivers of what the patient's presenting with. And we're really just waiting for this, you know, this diagnostic evolution, if you like. Because diagnosis may change over time, become clear with symptom progression, further assessment. Our role is to manage these the patient who's in front of us. We don't wait for the diagnosis, we treat what we see. I think my final thing I'd want to say here is that we think system, not structure. Think function, not flexibility. Think load, not just strength. And I think if you understand how the system behaves, you'll treat these patients far more effectively than if we focus on the label. And obviously in pelvic health, this approach is absolutely essential because this is where all the systems basically converge. So I think the clinical implications for us is it shifts management away, not purely biomechanical, not just strengthening, towards load management and recovery capacity, autonomic regulation, graded exposure to exercise and movement, symptom variability, education, addressing pain sensitivity. And this practical translation to pelvic health, we often see both pelvic floor overactivity and weakness at the same time in these patients. The pain can often be disproportionate to the findings, so they can often have an awful lot more pain to what you can actually find clinically when you assess them. They often have reduced tolerance to traditional strengthening protocols, and there's some evidence out there to support that. And then flares with stress, fatigue, and illness. So a system regulation issue, not just a problem with the ability to transfer load. So it might not just be excess movement, it's more poor control of movement under load, which is a big clinical implication for us in rehab. So why are heads and HSD managed together? Although the diagnostic thresholds differ, the clinical management strategies can often be similar. We look at load management, graded strengthening, pelvic floor, core coordination, autonomic system management, and a multidisciplinary care. Again, for rehab clinicians, it's not heads or HSD, it's the person in front of them. How is hypermobility affecting patients' load tolerance, stability, and symptom drivers? So if we come to the pelvic system, and this is a little bit like teaching your grannies to suck eggs, but just have a little bit of a think about this for a moment. And maybe not everyone in the audience is a pelvic health physio, I'm not sure. But we have to look at the pelvic girdle, the sacroiliac joint, levator muscles. We're looking at the abdominal caster. We've got to consider diaphragm, transversus abdominis, levator, spinal stabilizers. They all work together. We need to think about urogenital organs, the bladder, the urethra, the uterus, the cervix, and the vagina. And then we need to think of the venous system that drains blood from reproductive organs, bladder, and pelvic tissues. And why is the pelvic girdle vulnerable? Well, it's vulnerable because of collagen fragility, and that weakens, reduces the ability of fascia, ligaments to support the pelvic organs. Ligamentous laxity, because the amount of elastin that's in hypermobile patients' tissues is greater. So we also got an altered collagen structure, which reduces the passive restraint in these tissues, and then therefore the passive stability. So that really leads to impaired load transfer, inefficient force transmission between the spine, the pelvis, and the lower limbs. At a more microscopic level, we can get fragility of small vessels, but bruising, congestion, varicosities, and then dysautonomia, which is a big area of autonomic nervous system dysfunction that can affect bladder, bowel, can give you frequency, urgency, can produce a constipation, diarrhea, change the vascular tone, leading to postural orthostatic tachycardia syndrome, or POTS, which is very common in patients with HSD and heads. Mast cell involvement can contribute to chronic pain, inflammation, bladder-involved vaginal irritation. So there's a whole bunch of different levels of things happening in these patients that we always need to be taking consideration of. So how does pelvic girdle pain present in HSD and heads? Well, low back pain, usually SIJ pain. There's a widespread pain location in the sacroiliac joints near the dimples of the lower back. It can spread into the buttocks. It can go into the groin, the pubic symphysis. It can radiate to the hips of the thighs. And the pain behavior, which is really the key feature in these patients, is it's activity related. When they're walking, when they're standing on one leg, when they're climbing stairs. Turning in bed is a very, very common thing in pregnant women with sacroiliac joint pain. And it's the same in hypermobile patients. Asymmetrical movements are worse, putting on trousers or socks, anything with a torque through the pelvis. The patients often have a sense of instability, and I think that's really important because sometimes there is not a true structural instability there, but it's a perceived sense of unstableness that they might give way, which is quite frightening and scary. They often get all the clicking and shifting sensations, which sometimes have been written off as almost dismissed by medics. But if that's what the patient's feeling, we have to acknowledge that. They often have fluctuating symptoms, good days and bad days, influenced by fatigue, activity levels, hormonal changes, and stress. So as their period changes, or if they're reaching perimenopause, or if they're pregnant, that can have an effect on how their symptoms are. Maybe more so in pregnant hypermobile patients than non-hypermobile patients who are pregnant. There's muscle-related features of overactivity, guarding in the glutes, the hip flexors, the pelvic floor. There's weakness, fatigue, poor endurance, reduced coordination in the lower limbs. It tends to overlap with other symptoms. It can coexist with fatigue and also the dysautonomia again. Its clinical pattern is really difficulty managing force through the pelvis and over-reliance on muscle gardening and reduced ability to adapt to changing loads. So pelvic girdle pain in hypermobility patients is typically a load transfer and motor control problem, not just, or maybe not even, a loose joint issue. Sinead Dufour's integrated pelvic pain model it was devised around pregnant pelvises, but I find it quite useful to look at this when you're looking at hypermobile patients because pain doesn't necessarily indicate tissue damage. Sometimes it does, but sometimes it doesn't. Maybe it indicates sensitized tissue or a sensitized nervous system. Pelvic pain involves interacting systems, and which systems are contributing to the patient's pain need to be considered. Musculoskeletal drivers, common visceral contributors, psychological drivers, fear of movement, catastrophizing, and why wouldn't you feel that way? Lifestyle factors, sleep hygiene, fatigue, hormone changes, systemic inflammation, then maybe deconditioning from not being able to move or exercise in the past. We need to kind of always have in the back of our mind that when we're looking at these patients, there's more than one thing that we need to consider. So what are the rehabilitation principles? We need to prioritize motor load control, tolerance, progressive strengthening, stabilization strategies, looking at core muscle activation, pelvic floor and breathing coordination, hip and gluteal strength, proprioceptive training. And I have some resource information that I'll leave with the vet at the end of the talk that has some programs that specifically look at how you can progress these patients, maybe to give you some ideas of how you would progress them slightly differently to other patients that you might see. Load management, gradual graded exposure to loading, avoid prolonged immobilization, monitor fatigue and symptom flare cycles. Now, we can use external supports like sacroiliac joint belts. My favorite really that I use tends to be Sorolla. It's easy to get in the UK and it works pretty well. But other pelvic support that you find, or some people use kinesio tape. I don't use that a lot, mainly because of tissue and skin fragility, and maybe sometimes their immune system, there's some allergies to different glues and things that are on the tape. Compression garments, which are a bit more global, sometimes can help. And there's my colleague Granny Donnelly is doing some interesting work looking at the use of compression garments in running and athletes with incontinence. So there's going to be some interesting information about how these guys might be helped by using compression garments in the future. Then activity modification during flare periods, having a rest or taking some time off to get things to settle is not giving in, but just actually it's changing and giving the tissue some time to heal. Manual therapy can assist with pain modulation, reduction in muscle guarding, improved movement tolerance, and effects are primarily neurophysiological. So again, we can look at load management, change the load management failure, reduce neuromuscular coordination, not just ligament laxity. So there's some things that we can do to affect a change. So if you look at Sinead Dufour's rehab guidelines, she looks at external support with pelvic belts, SIJ belts, compression, like I said, motor control, hip strength, manual therapy, and clinical reasoning. So it kind of fits in a little bit with the pattern that I use in the clinic. So when we come down to pelvic floor dysfunction in heads and HSD, what's the overall picture? The overall picture is really that pelvic floor dysfunction is consistently more commonly reported in HSD and heads than in the general population. And now the exact prevalence really depends on how it's defined. All right. I think urinary, bowel, prolapse, sexual. So we don't really have a single global prevalence figure for PFD as a whole. The evidence comes from component systems, really. So continence is really, we know, a balance of three systems: a pressure system, intra-abdominal pressure; a closure system, the urethra and the pelvic floor and connective tissue support; and then a control system where we have nervous system, autonomic and central coordination and timing. Now in HSD and heads, we've got the pressure is often poorly managed. The way these guys breathe or don't breathe, the intra-abdominal pressure system is difficult to control and manage. Closure is often under-supported and control is often dysregulated. So we can get different values of pressure, closure, and control leading into the result being leakage, urgency, or incomplete emptying. And we have to remember that the pelvic floor doesn't work in isolation. It's part of this coordinated system involving local muscles, global movement, and the central nervous system control. Now, urinary dysfunction is the most commonly studied domain. A case-controlled study in 2019 by Gilliam et al. Found that there was 73% of HSD and heads patients with urinary incontinence versus 48% in controls. Across studies, urinary incontinence is consistently higher than normal, and it's consistently elevated across all ages, and it often presents early in life. Probably because of connective tissue laxity, overactive pelvic floor muscles, weak pelvic floor muscles, or a combination of both of those. Impaired bladder muscle contractility, impaired bladder support, prolapse-related outlet dysfunction. So the tissue, the actual pelvic floor and the muscles are not supporting the pelvic floor organs. And then dyssynergia, where everything is, the coordination between all of these systems is poor. So the type of urinary dysfunction that's seen is stress urinary incontinence is the most common, leakage with coughing, running, lifting, linked to connective tissue insufficiency, overactivity and weakness, urge, and then mixed incontinence. On top of that, they often have voiding dysfunctions where they have hesitancy, incomplete emptying, and intermittent stream. Now, we know if you're a pelvic health physio, you're used to seeing all this as your bread and butter. You see it every day. And I think sometimes how do we treatment for this? I think is it's not that much different to how we would treat people without hypermobility syndrome disorder or heads. It's just that sometimes the treatment takes a little bit longer. We have to go a bit slower. Fatigue plays a role. Bladder irritation plays a role, perhaps more in these patients, and sometimes a sense of connectivity or interoception of what's happening between their pelvic floor and their bladder incontinence is tougher than in the general population. So we can have mechanistic drivers of bladder dysfunction. They arise from the interaction between connective tissue, autonomic control, and pelvic floor coordination. So we get three key mechanisms are the fact that we get autonomic dysfunction, the central driver, you get dysautonomia, we get altered bladder signaling. So it's a sensory issue that produces urgency, frequency, or nocturia, because that information is being sent to the area in the brain to do with continence. And it's being misread, it's being misunderstood by the brain. You get poor bladder filling sensation or hypersensitivity, and that commonly overlaps with POTS. With connective tissue and structural support, you get reduced tissue stiffness. That leads to reduced urethral closure, pressure or support, bladder neck hypermobility, pelvic organ descent, so cystocele, so the bladder can prolapse, and that causes reduced passive continence mechanisms. We then have obviously the neuromuscular control, where we have pelvic floor overactivity or weakness. Both of them are equally as kind of disabling. We have poor coordination with intra-abdominal pressure, and then incomplete relaxation during voiding. So we have very complex situations with these patients, leading to like dysfunctional voiding patterns. So the pelvic floor capacity, the idea of it's not just weakness, but it's actually about capacity under load. It may be adequate at rest, but it can fail under load or movement because of poor pressure management, inefficient load transfer, or over-reliance on bracing. The symptoms are things like lifting, impact, prolonged standing. Now, the thing that's really important is these patients, which I think we see in not just heads and HSD patients, though, the pelvic floor can be both simultaneously weak and overactive. Hypermobile tissue leads to protective guarding. It leads to increased baseline pelvic floor muscle tone and poor relaxation. And that can lead to long-term deconditioning or reduction in strength in the pelvic floor and the pelvic girdle and the hips, causing insufficient ability to generate force for high load demands. So when the autonomic, what does the autonomic nervous system do here? It's common in HSD and heads, and it's a form of dysautonomia. The bladder effects are things like altered bladder muscle signaling, increased urgency and frequency, reduced sensory thresholds. And it explains the urgency without clear structural causes, overactive bladder presentations, bladder pain syndrome. We have sympathetic nerves, we have parasympathetic nerves. They're kind of widespread all the way from L2 all the way into the sacral nerve. So I think we have to be thinking more away, not just about the local nerves, but what's happening right up into the lumbar spine, and what is the lumbar spine movement like? What is the lumbar spine control like? And it goes all the way up into the pontine micturition center in the brain, the cerebral cortex. We've got the hypogastric nerve, we've got the pudendal nerve, we've got pelvic nerves, we've got sympathetic nerves, all involved playing into this role. So central sensitization is really important in these patients because they often have overlapping conditions where they have chronic pelvic pain, they have irritable bowel syndrome, widespread pain syndromes like fibromyalgia. So we get kind of like central sensitization is because of increased threat perception. They then learned protective motor behavior, which gives us pelvic floor guarding. That causes more urinary symptoms, urgency, frequency, and that feeds into autonomic dysregulation. So urinary symptoms aren't purely mechanical. There's a reflective protective system response, not necessarily a structural fault in these patients. So bowel dysfunction in HSD and heads, common symptoms or causes are things like constipation, where they get chronic, multifactorial, low transit time, outlet dysfunction. So maybe like prolapse or like rectocele. IBS-like symptoms where you have alternating bowel habits, where you have bloating, pain, you have constipation, then diarrhea, bloating and pain. Visceral hypersensitivity, so they don't like their abdomen being touched. Their organs seem very sensitive to palpation externally. You can get rectal hyposensitivity, where they have reduced urge with stool retention. And we have to identify it using like balloon sensory testing for that. Outlet obstruction is things like incomplete emptying, where they've got straining or they're having to use digital evacuation, and can be caused by positional change. It can be caused by rectocele. It can be caused by non-relaxing pelvic floor. We have a dyskinesia because of poor intra-abdominal pelvic floor, intra-abdominal pressure, pelvic floor coordination, relaxation. We get paradoxical relaxation, where the pelvic floor is not relaxing to allow the bowel to empty properly, although we're getting peristalsis in the bowel itself. With dysautonomia, we can get decreased motility, changes in blood flow regulation, changes in visceral sensitivity, and then there's a POTS and fatigue link here. This idea of redundant colon, where we might have an increased length of colon, which gives delayed transit, causes a mechanical like insufficiency, and then gives bloating and constipation. Connective tissue dysfunction, decreased bowel support, prolapse, decreased recoil of the tissue in the bowel, and then decreased propulsion. So it does not move the feces through the bowel in an efficient way. Then we come to pelvic floor load tolerance, where we have poor intra-abdominal management, pelvic floor over-bracing strategies, and then decreased force transmission across that area. I think pelvic floor paradoxical contraction, where you want the pelvic floor to be relaxing when it's actually contracting, can be protective and learned, and it can be tied in with pain, anxiety, and lots of other drivers. So physio management, what does it look like? I think pelvic floor muscle training, it's going to be strengthening coordination. It's going to be timing and relaxation. So I think it's like, what does the pelvic floor contraction look like? And using things like digital exam, but transabdominal and transperineal massage to look at the movement of the pelvic floor, the contraction and the relaxation. How does that coordinate with breathing? What's the timing like? In a sense, it's not always about how hard can you squeeze until we actually identify that they actually have a weakness, because we can't just assume that this is all about weakness. And in fact, they might well have a guarded pelvic floor that needs to be down-trained first, and then we go back to do the strengthening, which is sometimes hard to bring them on the journey, because you're asking them to, they feel they have to stay contracted to keep everything inside. So you're basically, you're asking them to do something that's not, it's counterintuitive to them. We want to optimize defecation mechanics. We want to look at posture, hip flexion, squat, stool position that we're all aware of, breathing, avoiding Valsalva in a way, because Valsalva doesn't really help with emptying the bowel. Use abdominal expansion with pelvic floor relaxation, cueing drop and bulge rather than push. Down training is really critical. We need to reduce resting tone and overactivity. Breath work, biofeedback, manual therapy, like kind of body awareness work. Dietetic input, obviously, if you're comfortable with sharing nutritional advice with patients and you feel you have that knowledge, that's fine. If you don't, then I refer my guys on to like a specialist nutritionist. Neuromodulation, looking at things like TENS and posterior tibial nerve stim, can be really helpful in the clinic, and you can use direct electrode stim or you can use electroacupuncture stim to get some changes. And I've just been learning recently about vagal nerve stim from Iveta, which has been a new thing to me. So I've just started to explore that a little bit. So I'll come back and tell you what I feel about that in the future. And then things like transanal irrigation, where you can use low volume or high volume, the installation of water into the bowel using patient-driven pumps to help with predictable bowel emptying and actually help with incomplete evacuation, which actually then kind of almost stimulates the bowel to work a little bit more and improve peristalsis. So if you're going to just talk about pelvic organ prolapse, and I know I'm just going to look at my time, which I've got 15 minutes, and this is included in the 2017 criteria, and it's often they present much younger. They're often nulliparous. They have a three-system failure. Again, poor intra-abdominal regulation from the pressure system, chronic straining, and inefficient load transfer. The closure system, the connective tissue laxity, decreased passive support, the pelvic floor is lengthened or less efficient. And then the control system, the same thing that we had before, where they get poor coordination between intra-abdominal pressure and pelvic floor, over-bracing, delayed activation, and then pain and fatigue and autonomic factors. So again, maybe a little bit more than in normal patients. And prolapse is not just weak tissue, it's a system-wide program. So improve symptom, what can we do for that? Well, we can improve symptoms without even changing the stages. We can reduce heaviness, dragging. We can reduce bulge awareness, reduce urinary bowel symptoms. We can increase confidence and activity. Symptoms often improve more than the anatomy, though. You can still often assess these guys as having prolapses, but actually their symptoms are improving significantly. We can teach intra-abdominal pressure, breathing, avoid breath holding, bowel strategies, load management, lifting during lifting and sport in the pressure system. The closure system often is pelvic floor training, reduced overactivity, strength, endurance, and timing. And I think applying specific strengthening and conditioning principles to the floor, looking at strength, looking at endurance, looking at power, and not training them all at the one time, but doing strength first. And once they've got some strength, then add endurance. And then once they've got some endurance, then add power. Sometimes when we're training our pelvic floors and we're doing strength, endurance, and power all at the one time, we're overloading them. We're overtraining them, but we're underloading them. So we need to work them maximally, but we need to make sure that they're not being overtrained. Load them heavy, load them as hard as you think you can manage or you can apply to that patient in front of you, but don't overtrain. Support strategies are things like toileting, manual splinting, external support, and pessaries. Then we kind of go to the control system and we look at motor control. How do we get the pelvic floor and the diaphragm and the abdominals working together? Because we work them, we take them into the gym, we take them into graduated load tolerance, gradual exposure to lifting, impact, and sport. Build capacity. Don't avoid, adapt what we're doing so that they can manage to do the activities without making their symptoms worse. Address key drivers like constipation, coughing, weight, if they're a bit overweight, deconditioned, and then hypermobility patterns. We want to look at education is critical. We need to maybe explain to them that just because you have a prolapse, it does not necessarily equal damage, and that you have to avoid using and moving and using your pelvic floor, safe movement strategies, and this self-management long term. So sexual function impact in HA is something that isn't really spoken about very much. It's something I always talk to my patients about, because if you look if you look at patients when they fill in female sexual function index scores, looking at desire, arousal, and lubrication and pain, they all have low scores. They all have reduced scores. 32 to 77% of patients have dyspareunia, have painful penetration. They have vulvodynia, they have vestibulodynia. They often have persistent they don't often, but I think in this group, if I see persistent genital arousal symptom patients, then they can often be in the hypermobile heads in HSD group. They can often have labial edema and swelling. They often report reduced satisfaction and avoidance. So what happens is they feel that so persistent genital arousal is where, if you've not seen many of these patients, it's a really disabling condition where you have the genital changes of arousal, but not the cognitive change. So you have no heightened arousal in your cortex and your brain, but you perhaps have lubricated. You have a lubricated vagina. You have maybe an engorged clitoris. You have a sense of tingling and genital arousal without the mental state to go along with it. So you can be doing your shopping or doing your cleaning, and patients often report it to me a bit like the being in the same position of just about to sneeze, but it never arrives. And sometimes it's a funny condition in the sense that people kind of don't talk about it, and there's a bit of stigma and shame surrounded by it. And I think but it can be really, really disabling psychologically and physically, because you then become a little bit hypersensitive when you actually want to have sex, and masturbation or sex doesn't necessarily alleviate the symptoms for very long, if at all. The other thing that it's common in HSD in heads is like labial edema and swelling before and after sex. So maybe that's a chronic thing, or maybe that's after they have sexual interactions. So again, what happens really is really to do with the multi-system drive, where the tissue and vascularity, there's microvascular fragility, which leads to poor perfusion. You can get pelvic venous congestion, which and leads to heaviness and swelling, which then can be kind of compounded. You think they might have a prolapse because of the heaviness and swelling, but it's actually just being driven by the vascular system. Again, connective tissue laxity leads to reduced support and altered mechanics. The pelvic floor closure system, again, overactive, non-relaxing. Dyssynergia during penetration. So if you put a finger, a penis, or a toy close to the pelvic opening, the pelvic floor tends to contract and not relax. Maybe there's reduced excursion or poor lengthening of those muscles or the vaginal canal. And then pain with attempted relaxation. There's also the sense that if that has been a continued thing, that sex has been pain for a while and you've not reported it to anybody, that there's a predictive component in your brain that you always think it's going to hurt. So you preempt that pain by getting tight before you even have sex. We have central sensitization, which amplifies the pain. We've got autonomic dysfunction. We've got altered arousal signaling, and we've got predictive guarding patterns in the nervous system. Then maybe we've got pressure system issues with poor intra-abdominal regulation with downward load, and the prolapse contributes to discomfort during sex. Maybe immune. I've had one patient that was actually had sensitivity to her partner's semen, and they thought that was really tied in with her mast cell activation, caused pain, irritation, and swelling, heightened tissue sensitivity, and they kind of got around that by using condoms. Which is fine unless you want to try and have a baby, of course. But for them, it was a very practical, simple solution, which wasn't one that was particularly well accepted at the beginning, in the sense that they were in a relationship, they were monogamous, and they felt they had wanted to try other forms of contraception, but this they couldn't do that because of her response to his semen. So again, the clinical implications with these patients, the symptoms aren't purely a local tissue problem. It's often multi-system and overlapping drivers with this high variability between patients. And what we can do with these guys is we can down train overactivity, relaxation, strengthening initially, restore pelvic floor excursion, coordination, address pressure management, talk to them about graded exposure to intimacy and activity. I feel that sexual activity is an athletic endeavor, and we almost need to, as physio as we can, we might not want to get into the psychosexual realm of this, but we can definitely look at it as a positional strength, endurance, and functional activity that we can be involved in helping make better for patients. And then finally, pain education and desensitization strategies. One thing I say is that I think with all of these patients, they've often been quite traumatized, if that makes sense. And so we do need kind of trauma informed care. So I think we can't optimize pelvic function without first creating safety. So we have to just assume that these guys are they're coming from a trauma background. They've had some kind of trauma, and we need to recognize the impact of trauma on health, behavior, and symptoms. We need to create a safe collaborative care environment. We have to avoid re-traumatizing them, and we also it matters because there's a high prevalence of trauma in pelvic pain populations, the strong link with chronic pelvic pain dyspareunia. These patients have often been dismissed, they've often been disregarded, maybe not taken seriously, or they felt they haven't been taken seriously. We need to think of safety with physical and emotional safety, give the patient the choice at all times, collaborate and make everything about a shared decision-making process. And then they have to develop trust where they feel that there's transparency, clear communication, empowerment, build confidence, but not dependency. Give them agency to look after themselves. I think communication where we can play a big role with validation, that it's real and common, avoid blame or minimization, and be aware of things like triggers like touch, position, and language are all super, super important. So my final take homes really are these symptoms are real and multifactorial, that it's not just weakness or damage. Change is possible. The physiotherapy role is really create safety, improve control, and build confidence. So enable function, not fear, is my final message I have for you. And thank you very much for listening. Stop sharing. So we might have some time for questions, I think, if anyone's got any. I don't know if there's any in the chat, Iveta.
Yes. Can you see the question, Bill, in the chat?
Let me just see. I can go here.
Oh,
Yes, I can do.
Yeah.
Right. So
that's really interesting question, actually.
So some of them are in is it the okay is that would you like to say something in the end about hypermobile kids older than 6 years still having problems with incontinence? Should you treat them as grown-ups, or is it something special we should think of? When should they seek a specialist? So I think it's a good question. It's also, I think with kids, it's a what I would want to know is, are we talking about nighttime leaking, like incontinence, like enuresis, or are we talking about daytime incontinence? So is it when they're running around, or is it when they are? Yeah, okay. So if it's daytime, then it's about pressure system management. It's often about timing. It's about control. It can be about weakness, but more often than not, it's probably more like to do with maybe like a intra-abdominal pressure management, and pelvic floor control. So it might well be that you'd want to know what they do, what's happening when they're playing, and what they're doing when do they play sport, do they run, and do they leak during those activities. For me, it's difficult to assess these guys traditionally, but it's really easy to assess them using a transabdominal ultrasound machine, because you can look and see what the intra-abdominal pressure effect is having on the pelvic floor. You can see whether when they breathe in, does the pelvic floor go down? Are they able to contract it? What happens when they cough? I think and with kids, it's about how you treat them. Really, I think is you have to turn all of the stuff that they do into a game. You have to what I'm trying to even think what I say with these kids. So I think what I say, I want to know what the pelvic floor contraction looks like. Are they able to do that themselves or not? Do they get the idea of with the ultrasound, it's very easy to, you don't even need to be that medical. You just ask them to make their pelvic floor bounce up and down. And they often just do that because they're children and they don't understand that that maybe that's a hard thing to do. Sometimes that's not a problem. If that's a problem, you have to introduce things like blowing through straws or blowing balloons or sucking up through straws to see if you can get some change in the pelvic floor. And I do that while I'm scanning them to see if there's a change. The other thing is you scan them standing up. If you don't have a scanner, the only other thing you can do is palpate them across their tummy to see if you're getting some contraction. The other thing that often happens, obviously, is are they so if you want to do so you make all of the treatment a game, really. The other thing you want to know is their pelvic floor too switched on and not switched off? Is it not switching off? And if that's the case, they need to do kind of games, rolling about on foam rollers, rolling about on kind of Swiss balls, anything that massages their abdomen to make the pelvic floor relax. Maybe sitting on spiky balls again, or soft balls, but it always has to be a bit of a game. It can't just, you can't make it completely, you wouldn't treat them the way you treat an adult. And then what is their, what does their activity do to their pelvic floor? Is there things you can work on using elastic bands to strengthen their hips if it's a weakness problem? Oftentimes you have to make sure they don't have constipation, because that can be one of the biggest issues with incontinence in kids. Now, I think that you would oftentimes you don't need to do very much or change very much in these children to get a big response. And actually, I see a lot of kids in the clinic, and to be honest, I probably see them once or twice, and that's enough. And I send them away. I video the session with their parents, and I send it away with them so they follow that program. And it tends to be fun and games: squatting, loading, rolling, a lot of crawling on the floor. Karina Syracuse from the States is a neuro/pelvic floor physio, thinks that developmentally we need to get children on all fours doing kind of like reptilian type climbing to almost to make their pelvic floor connect with their hips a bit more. So I'll use that. What else would I say? I think that's what I say. Now, about nighttime, if it's nighttime, that's a slightly different thing. And I have nighttime, for me, I often think is a bladder sensory thing, or it tends to be more bladder sensory than pelvic floor. And so with kids, if they will tolerate it, vagal nerve stim or posterior tibial nerve stim on their leg is quite useful, because they can do that when they go to bed. But during the day, if it's a child that's weeing the bed at night but not during the day, I often think they have an overactive pelvic floor. So doing stuff to downtrain that with breathing and loading and using spiky balls can help. So that's what I would say, although every kid, again, is different. There was another question here, but what kind of exercise do you mean when you talk about strength and power? It sounded as if they're different. To me, it sounds the same. Okay, so by definition, strength is the amount of force that you can generate with one contraction of a muscle. So your strength is really how much newtons can you produce when your muscle contracts it to its maximum. Power is how quickly can you produce that. So power is a rapid contraction, and power is like a quick flick, the way that we would talk about a quick contraction. Now, there's two things about power. Power it's a rapid contraction, but there's a kind of a subdivision of power called rate of force development. Now, RFD, or rate of force development, is the ability to produce a spike in muscle activity and when we need that is when we cough. So when we cough, we need a spike of activity like that. We need a clap of activity that shoots the EMG up to get a really rapid but quite strong contraction for a microsecond to make sure that produces enough force that keeps the urethral closure pressure greater in the urethra than it is in the bladder. Now, we need to do, and I think sometimes when we've been training, I believe that when we've been training power in pelvic floors in the past, we've not been doing it fast enough. Because if you say and again, the and again takes too long to say to actually get the contraction to work fast enough. So what I do in the clinic is, because you can either do because the contraction has to be that fast. It can't be again. You can't do it verbally. There has to be some other way of doing it. So you can click your finger, because that's fast enough. Okay. If you want to quantify it, a way to pardon me, a way to quantify it is using a metronome, you know, like the musical timer, and you can download metronomes for free onto smartphones, and I will get my guys to do start round about 60 beats per minute. So you have like a beat every second, so their contraction goes like that. Okay. And then what happens is what would then happen is you would then, in a 15-second time, they would do that. Then we have a 45-second rest. Then they would come back to that 15 seconds, but you could actually turn up the beats per second rate. So you can objectively progress that exercise, because I really believe that when we're treating pelvic floor muscles, we should be applying strength and conditioning principles to them. So we want to strengthen first. We want to make sure that they know how to contract. Once they know how to contract, then we have to know they can do a maximal contraction. Once we do a maximal contraction, we have to then discover what their repetition maximum is. So what is the maximum number of contractions they can do before they fatigue? Now, in the past, we've often thought that's 10, but in actual fact, when you scan these guys with a scanner, you can see that sometimes it's 4, and sometimes it's 6, and sometimes it's 3. And so you have to find their repetition maximum, because it's the same thing if you're in the gym and you're doing biceps curls and you can only do 3, and then you go and do 10. The 7 that you did after the 3 that were good were a waste of time. They're not very efficient, and they're not good to strengthen. So I think sometimes, again, I think I said it once already, that we tend to underload pelvic floors and overtrain them. And we must be really, I think, vigilant that we're working them as hard as we can within the strength and conditioning principle guidelines to get the best outcome. So to get strength separate from power. But I would normally do strength, and then I would do endurance, which is the length of time you're able to maintain the contraction, which we've been doing for a while in pelvic floor. Power for me is the one that we probably do least well or least efficiently. And that's really not in a non-functional environment. And then once you've got that together individually, you have to take that and put that into function. What is it they do? If it's sex, what does their sex look like, and how can you strengthen around that? If it's going to the gym, what does going to the gym look like for them, and how do you connect those things together? Thank you. Good question. And yeah, I think someone said I'll send the slides, and I'm pulling together a resource page with some of the stuff on that I'm happy to share as well. Cool. Perfect.
Thank you so much, Bill. Thank you for all the questions. If you have more questions, just send it to us. We can send it to Bill, if it's okay for you, Bill.
Absolutely. Yeah.
Fast and Furious, this one. It was a lot of information.
A lot of information.
As always, but we definitely need to hear more about these patients. So thank you very much, Bill. We keep in touch, and have a nice day. And
thank you. You too. Thanks for coming, everyone. Thanks for listening.
Yes.